International Thalassemia Day, today being International 8th May International Thalassemia Day, so it is our pleasure to have this topic. And as you all are aware of this year's theme being Be Aware, Share, Care, strengthening education to bridge the thalassemia care gap. So as a pediatricians, we know how much these children suffer. So it is our duty to diagnose early and how best these children and their families cope up with this thalassemia and let them have a normal life and a very qualitative life. So as a pediatricians, we have a greater role in making these children more lively in their childhood. So I thank you all, and I invite all the today's guest lectures on this topic. So we'll have a very good session tonight. Thank you all.
Yeah, if Dr. Kurapati is there, Dr. Kurapati Pradeep.
Yes, sir. Yes, sir. I'm here. Good evening, sir.
Yeah, he is the unsung hero of thalassemia. He is from Khammam. He does a lot of activity on thalassemias. Welcome, Pradeep. We have Dr. Suman Jain,
Thank you, sir.
madam.
Thank you for the introduction.
Suman Jain, madam, she doesn't need much of introduction. She is into sickle thalassemia since I think 35 years, madam.
Yes, sir. Yes, sir.
And when we think of thalassemia, it is madam first name, and she is the only NGO which does for sickle cell and thalassemia in the Tri-Cities of Hyderabad. We have Parinitha madam with us.
Hello, sir. Hello, everyone. Good evening.
Yeah, hi, ma'am. And we have a senior most pediatrician, Dr. Dandamudi Ramana, who is a consultant at Little Star, and madam also, Parinitha Gutta, is she has done her CCT from UK, if I'm not wrong. And Dr. Ramana has rich experience, so he's in Little Star Hospital.
Good evening to all, and thank you very much for the introduction. Thank you, sir.
Dr. Srikanth Marda is there. Has madam joined? And we have Dr. Sandhya, who's a consultant at Rainbow Children's Hospital and works along with Madam Sirisha Madam.
Good evening. Good evening, everyone.
Hello?
Yeah, madam.
Sir, so sorry. I haven't seen that it is at 8 o'clock. I thought
Okay,
it is
ma'am.
at 8:30. I'm very sorry. I'll share the screen. Visible. So
Every
you
year
have
we,
to enable me to,
yeah,
share
shall we
the
start?
screen, sir. You have to enable me to share the screen, sir.
Yeah, I'll do that, ma'am. I'll do for you.
Ah. Others also.
Yeah, I'll do,
log
ma'am.
in,
I'll do
sir.
for you.
I can see Srikanth and Sandhya.
Dr. Seshu Madhav is there? Dr. Seshu, sir?
Yeah.
Yeah,
I'm
Bhaiya.
here.
Again, shall we? Sirisha madam has started. You give your remarks and we'll start the program.
Yeah. Good evening, all. It's a pleasure to invite you all to today's Zoom meeting. Today's topic being today being an International Thalassemia Day. So today's topic is very apt: comprehensive care, thalassemia child and family, what pediatricians should know. As a pediatricians, we all play a major role in taking care of these children. So I hope the panel is all are experts in this field. Dr. Sirisha madam, Dr. Ramana sir, Dr. Jain and all others. So I think we'll have a very good lecture. So let us all make use of this Zoom meet. Thank you all.
కూడా ఉన్నాడు యాత్రగా ఆయన కూడా ఉన్నాడు కానీ దీంట్లో ఇప్పుడు మాట్లాడే ప్రదీప్ కాదు.
Yeah. Every year the Thalassemia International Federation declares one theme, and this year the theme is be aware, share care, strengthening of the education to bridge the thalassemia care. And we don't have much of the data on the incidence and prevalence. I was really shocked today morning by the incidence and prevalence being shared by the Institute of Genetic Studies. They have done a pilot project in 10 districts of Telangana. Among the 1,000 screened for thalassemia and sickle cell, there were 10%, most of the districts in the adjoining areas of the tribal. Asifabad has 9.6, Adilabad has 10.6. It is really alarming, and one of the study at Petlaburzu shows in the antenatal mothers, it is around 2.15. This article was recently published by the Institute of Genetic Studies. So much has to be done in this field. We have pioneers here. Dr. Sirisha madam, who is the moderator. We have Dr. Sandhya ma'am, Dr. Suman Jain, Dr. Parinitha G, senior most pediatrician Dr. Ramana, Srikanth Marda, and Pradeep, the unsung hero. If Dr. Vamshi is there for his remarks, and then I'll hand over to Sirisha ma'am.
Yes, good evening all. Good evening, President YASHOWANTH RAO garu and Shesh Madhav sir, President, incoming President, and all the seniors. I could see Dr. Suman Jain and Parinitha Gupta and Dr. Sirisha ma'am and Dr. Keshav sir and Ramana Dandamudi sir. Last year, if you remember, we did at KIMS a wonderful program, and my friend KV Rao and all others. There is a study, as our president was saying, that Institute of Genetics, they have categorized the areas and some of the castes also, like Lambadas, Mudiras, and a few of the castes they have specifically mentioned where the percentages were little more. Although this percentage altogether was less than 50%, the other 50% still are yet to be traced. How by making all the studies, we are treating the patients, but there is no proper data. So I request all the hepatologists in association with pediatricians who come across all these anemia cases to thoroughly investigate and do the needful. Thank you. I'm Dr. Vamshi Konle, Secretary of PATS. Thank you for giving me opportunity. Thank you all the speakers for coming and joining us. And please go ahead. Thank you. Over to you.
Over to Sirisha, madam.
Thank you, sir. Thank you. Yeah, so it is our honor and privilege to do this session on this day, Thalassemia Day, as we discussed in the morning also, like, you know, Thalassemia Day is not a celebration, but it is to improve the awareness, not only in general public, also in the medical fraternity, where there are certain things are not discussed, like, you know, the transfusion programs, chelation program, and how to monitor them, how to screen them, and the management of the family, permanent cure options. So all these, a lot of things are there, which needs to be discussed in these kind of webinars. It's a great initiative by PATS, the IAP team. I welcome all my panelists. None of them need introduction already. Dr. Yashwanth already mentioned all the names of the doctors who are there in the panel. So I will straight away move on to the discussion of the part of the panel. So as we know, like, you know, for the past more than 10 years, I've been hearing that, you know, the incidence of new cases is around 10,000, but we all know that it is tip of iceberg. So there is a strong need to control this disease and then see the thalassemia free, society in the future. So let's see, like, you know, what we need to do to improve the quality of life of the existing patients. So we'll start with one simple case scenario. So it's a 6 months-old boy who has been brought with irritability and some difficulty in feeding. But there was no history of fever, cough, or vomitings. There was, and the baby is otherwise breastfed baby. Also got introduced already for the complementary feeds. Feeding was adequate. That was not a reason for irritability. And growth and development were appropriate for age, and there was no significant antenatal or postnatal or other significant history. On to third-degree consanguineous marriage couple. Anthropometry was appropriate for the age, and the prominent finding was per abdomen examination revealed mild to moderate firm hepatosplenomegaly. So with this clinical history, Dr. Sandhya, so as we have some of the students, I'm sure some of the students also would have got logged in. Dr. Sandhya, can you tell us, like, you know, what are the directions one should take? Because that is the first step we should approach for baby.
So, thank you, ma'am. For this kind of a presentation, we have to think differentials in the tune of either some kind of an infection. The points against it being that there is no fever in the child was well up till then, no other symptoms. Other hematological causes do lead to hepatosplenomegaly in a child with anemia. So common is being hemolytic anemia, which can present at this age, 6 months of age. So common thalassemias or sometimes other anemias also like sickle cell anemia, spherocytosis can present. Other causes like intrauterine infections, less likely at this age. Tumors or infiltrative disorders like leukemias also can present with this kind of a finding in a 6-month-old child. Rarely, storage disorders can also present early. But given the clinical scenario and sanguinity and everything, I think more like a hemolytic anemia.
Okay. How about nutritional anemia? What are the points against and what are the points in favor of nutritional anemia?
Nutritional anemia, one thing, organomegaly is usually not seen in nutritional anemia unless there is overriding sepsis, ma'am. Also, baby was adequately fed, growing well toward that age. Anthropometry was appropriate for age, as mentioned here. So nutritional is a little less likely in this scenario.
Yeah. So you may expect some amount of mild organomegaly, which may be soft secondary to severe anemia. But as you said, like, you know, it is unlikely that you get moderate firm organomegaly. So Dr. Srikanth, how do you approach this case? How you would like to investigate? What are the first investigation you want to do and then subsequent investigations to confirm your suspicion?
Is my voice audible, ma'am?
Yes, yes.
Good evening, ma'am. Thank you. So going back to the case, so approach to this case. So when we come to hematological cases, half of the times our history and clinical examination would guide us as how we need to go about. So in this case, we take a 6-month-old who's been breastfed and started on complementary feeds adequately and well-thriving child, no history of infections, and significant pallor is there, and firm organomegaly, which is mild to moderate. If we think of only nutritional anemias, we expect firm organomegaly. I mean, we don't expect firm organomegalies. It can be mild degree and that too soft organomegalies. So clues are there which point towards hemoglobinopathies. So approach will be first investigation, as always history and diagnosis is done, coming to the complete blood picture. So which tells about the hemoglobin, different red cell indices, and the peripheral smear being very, very important in this case. So first up front, I would like to get a complete blood picture, look at the hemoglobin, other RBC parameters, total counts, and platelets. And then from then on, I will take over as how next to go about it.
Yeah, so this child had hemoglobin of 5.5, MCV was low, and WBC and platelets were fine. This is the peripheral smear. Dr. Srikanth, how do you read this peripheral smear?
Yes,
and what does it say?
Yeah, so seeing this peripheral smear, definitely, mainly when we see at a peripheral smear, we need to see different cell lines and each cell line at one particular time. So that is like first look at the RBCs, then the WBC pattern, then the platelet pattern. So here mainly we are more concentrating on the anemia because hemoglobin is very low, total counts and platelets being normal. So the RBC cells, we can see definitely they are microcytes and they are hypochromic. You can see the central pallor which is there, it is more than 1/3. Otherwise, you don't see this degree of pallor in these cells. And then you see target cells. So target cell is the one where you can see the central thing is there, and surrounding you have a hypodense area. So they are the target cells. You can see microcytes, hypochromic, and different forms of cells you can see. Teardrop cells are also seen. Okay. So it's a microcytic, hypochromic, anisopoikilocytosis with wide variation of cells being seen. So that will be the interpretation from the peripheral smear.
Yeah, absolutely. So whenever we see this kind of smear, so hematologists need simple peripheral blood smear to diagnose everything, isn't it? So going by the peripheral smear examination is very important, and then that clinches the diagnosis. And as you rightly said, we also have to look at the other cell lines. And here other cell lines are normal, and you have to go ahead and do next subsequently your iron studies and then your HPLC or HB electrophoresis to confirm the diagnosis of your hemoglobinopathy. So this is a little bit about thalassemia. Most of you know about it. I'm skipping that. So Ramana sir is there, I guess. Sir, are you around?
Yeah. Good evening, Dr. Sirisha.
Hi, sir. Good evening. So do all thalassemias require transfusion? When do you decide on transfusion, and who are the categories like that require transfusion, sir?
Definitely not all the thalassemics do need transfusion. You would say quite significant categories thalassemia major, where definitely they would present before 2 years with significant growth failure and hepatosplenomegaly. They would should go on to the transfusion program. Certain the non-transfusion dependent thalassemics like all intermedia and sickle thalassemia, E-beta thalassemia, mild to moderate, these don't require transfusion. We have to be quite clear because often some of them, they can present after 2 years with the hemoglobin of 6, 7. Still, we might think about thal intermedia or thal other syndromes, which they don't necessarily, but here you could see in kind of our background where a lot of children don't necessarily come to you straight away. The main significant factor is the growth failure. These children who supposed to have transfusions, not bringing the parents to the professionals that definitely would be evaluated properly and put them in the all major category.
Absolutely, sir. I think this is the picture which will tell us, like, as sir has already mentioned, all THAL majors, which is a clear-cut picture, straight away you go on to transfusion. But NTDTs, you monitor their growth, you monitor their hemoglobin, monitor their hemolytic features, then decide whether they require regular transfusion or not. And then, of course, you can go ahead and try hydroxyurea in NTDT variants and then decide on transfusion. So, Dr. Parinitha, can you tell us what is the pathophysiology of hemolysis in these children and what are the symptoms in thalassemia? At
Good evening,
different age categories, I should say.
Yeah. So it's a huge thing. So to be brief, the main symptom is anemia in thalassemia major, and that's because of ineffective erythropoiesis. So because of ineffective erythropoiesis, they're anemic, and also the spleen is more active because of the whole issue, and then you develop splenomegaly and hepatomegaly as well. So because of the anemia, there is poor growth. There can be poor growth, and both height and weight is affected, and distended abdomens and all. So first, there is no system that is not affected by thalassemia as such. And because of the issue of lifelong transfusions, there is a issue of iron overload. So no system is literally spared because of thalassemia, and the iron overload starts occurring firstly in the liver, and not to forget the endocrine system, which is very sensitive to the iron. So that's what I would say. And the other thing is, after liver, heart is simultaneously or sometimes
Your voice is breaking, Parin. Your voice is breaking. You have to unmute.
Yeah.
Sorry.
So the one of the significant causes of death in thalassemias is because of cardiac issues. That is because of the cardiac iron overload, and then the bone deformities and bone health issues, and also because of ineffective erythropoiesis. If these children are not adequately transfused, they can develop hemolytic phases, and with like flat nasal bridge and flat maxilla and bone deformities, etc. So it goes on and on.
Yeah. So absolutely, it depends on the age where you are looking at the thalassemia child. Initially, you may just see the organomegaly and pallor, but later on, the features related to end organ damage will come into the picture. My next question is to Dr. Suman Jain. So, Dr. Suman Jain, many times sitting in the Thalassemia Society, you see the children in the post-transfusion status. How do you take them forward?
Yeah, the patient when comes to us with the diagnosis only, sometimes we diagnose other children extended family screening or siblings and all. So child with coming with the post transfusion, first we do the CBP and see what is the hemoglobin. If the hemoglobin is less, if it is less than 8 or 7 and all, then we have to take the history, how many times he has taken the transfusion, and accordingly we make the flow chart. They have to maintain hemoglobin between 9 to 9.5 gram before transfusion, pre-transfusion hemoglobin, and also when the patient is on the transfusion after 12 transfusion, we have to check up for their ferritin level, and also other organ testing, because this child doesn't need only blood transfusion and iron chelating drugs. We have to monitor also. For monitoring, we have to do the biochemical parameters like liver function test and creatinine and serology. We do every 3 to 4 months, and then ferritin level every 4 months. We do the ferritin level as a serial thing. And once in a year, after 8 years of age, we do other tests like thyroid and diabetes and bone monitoring like DEXA scan and all, which we don't do in our case. T2 star MRI once in a year, 2D echo, and endocrinologist opinion. These are the two workup we do. If I miss, please, Sirisha, you also add into it.
No, absolutely right. In the sense, what you mentioned is taking the child forward, comprehensive care of the child once you diagnose thalassemia. But if a suspected case comes in post-transfusion status, how do you confirm that it is thalassemia major?
Yeah, sometimes when they come as a post-transfusion, this is very difficult. Even if you are doing HPLC after 3 to 4 months also of the transfusion, it may come normal, you know. Then we have to do, if we suspect it is a thalassemia major, then the parents testing HPLC has to be done, and child's molecular testing has to be done to confirm the diagnosis.
Absolutely, yeah. So both the parents being minor or doing the mutational status of the child itself, like, you know, will clinch the diagnosis. Most of the times, once we miss the boat of doing HB electrophoresis or HPLC pre-transfusion, we end up having trouble in documenting high HbF even in a thalassemia major child. Hence, we always, like, you know, insist on collecting the extra samples before transfusion, so that which can be used for electrophoresis even later also. Okay,
Yeah.
so Dr. Prajna is around, I think. Okay, Dr. Prajna, can you please,
Hi.
can you please enlighten us on, like, you know, various mutations seen in thalassemia, how it differs in India versus abroad? You know, what is the implication of those molecular testing and all?
Yeah. Right. So before we move into that, continuing with what Dr. Suman Jain was already telling, so usually in the post-transfusion status, or if we have to do prenatal genetic testing for subsequent pregnancies, mutation analysis is absolutely essential. So there are two main strategies of doing mutation analysis. One is, if you already know the common mutations in your population, you could use the cost-effective approach of doing targeted mutation testing for the common mutations alone. And then if those are negative, you go with the rest of the mutations by doing sequencing of the rest of the genes. Or upfront, you can go for sequencing of the entire gene because it's a small gene. It has only 3 exons. So you can just do Sanger sequencing. You don't need to do next generation sequencing and all that. Now, coming to the common mutations throughout the world, the IVS15G2C mutation, that is the most common in all populations, including the Indian population. But other than this common mutation, there are some mutations which are more common in the Indian population. So, especially in people from the northwestern part of India, the Punjab and Sindh areas, for example, the 619 base pair deletion is supposed to be one of the most common mutations. Then elsewhere in the country, including in our population, there are some other mutations. They're given some conventional names like codon 4142 mutation, codon 89 mutation, IVS11G2A mutation. And these are all like conventional notations. Nowadays, there are standard terminologies for all of these. And if you get the report, you may see the mutation written in a different way, which would be as per the standard notation used now. But mostly, most labs would also mention the conventional names because most of us are familiar with these conventional mutations. Whereas in the other populations, such as the Mediterranean population and elsewhere in the world, where thalassemia is common, Sicily and Cyprus and so on, you may have different mutations which are different from what we see in our population. So it's important to know which mutations in our population will be common, because if you use the common mutations which are known to be common in, say, the Mediterranean region, and you design a common mutations targeted testing based on another population's common mutations, that would not work for your population. So you need to know which ones are common for your population and base your targeted tests based on those. That would make it more cost effective.
Thank you very much, Dr. Prajna, for raising the appropriate point, like, you know, when we are asking for the testing, what we should know, and then the doctor who is doing the testing also what they need to look at. So, Dr. Pradeep, are you around? Can you please tell us about transfusion
Yes,
program
ma'am. Yeah.
guidelines in these children?
Yeah, as Dr. Ramana sir has told, like every patient, like every thalassemia child usually doesn't need any the blood transfusion frequently. So we'll have to know, first thing is when to initiate the transfusion therapy and whom to transfuse. First thing, and how do you process the blood, which is effective and which is a safe transfusion therapy for thalassemia major children. And we should know whether is there any optimal hemoglobin level for effective transfusions. So we'll have to know all this. So initially, like to decide whom to transfuse, we'll have to go for the basic investigations, like the confirmed laboratory diagnosis of thalassemia major, of course, and the laboratory criteria being the hemoglobin of less than 8 or 7, on any 2 occasions or greater than 2 weeks apart, you should exclude all the other contributing causes like infections and all. And of course, the laboratory and other clinical criteria, including even the HP is more than 7, with any other poor growth or facial changes and some extramedullary hematopoiesis cases. Usually, what we recommend is for transfusion is leukodepleted RBCs. So, as we all know, we have different methods of leuko. Hello.
Hello. Yeah, we can hear you. Hello, Dr. Pradeep. I think Dr. Pradeep got disconnected. Yashwant sir, probably you can ask him to join. Meanwhile, we'll just continue with the questions. So there are various transfusion regimens that are discussed in these children are like, popular one is Moderator. You are there, Dr. Pradeep? Okay, so water transfusion is the popular one, which is like you always have to maintain the hemoglobin above 9. Hypertransfusion, super transfusion was in practice in the past, but that is no more in the practice. Super transfusion can cause cytopenias, pancytopenias, because you get the negative feedback to the bone marrow. Hypertransfusion is the regimen where you follow when you are doing the transplantation. So a couple of months before transplantation or few months before transplantation, you want to put them on hypertransfusion. Otherwise, just to ensure the growth, moderate transfusion is good enough for them. And the concept of doing extended cross matching before first transfusion is always should be there in most of the units, so that when they develop antibodies, you should know how to proceed with the further transfusions. And we always have to counsel them for regular transfusion to begin with, maybe 4 weeks, but as they grow, it can be once in 3 weeks or once in 2 weeks also. And look, as Dr. Pradeep already mentioned, it needs to be leukodepleted, which has to be pre-storage filtration. So pre-storage, post-storage filter difference we all should know. Pre-storage will also cut down the release of the cytokines from the WBC. So hence, pre-storage is always preferable compared to post-storage. The other ways of leukodepletion are, doing the irradiation and saline wash. There are various techniques of leukodepletion other than using the filter. But the popular one is using filter most of the times, and second one is irradiation before the transplantation. So Ramana sir, can you please tell us blood product safety parameters, what we should do in these children, and then how and monitoring for transfusion reactions and all?
Yeah, thank you, Dr. Sirisha. So basically, we all know the blood transfusion is the heart of the thalassemia program, because we all know this one is management and second is prevention. So how effectively we can do this blood transfusion program? First, let us know, we need to look at the one is important is counseling the family about the requirement, and then the way of doing rightly. And second thing, also equally important, if there are grown-up children or big children, we need to kind of include them the counseling. And the other side of it is as on today, we need to be very, very important is to monitor the transfusion systems, how they are happening, like about the blood bank and transfusion center. These are all very, very important to have a safe blood to go through. First, let us start about the blood banks. They should have all the facilities, particularly looking at the patient's exact blood phenotype and extent phenotype, if possible genotype, which is not possible in India. But that also is a mandate, because for the future we will see several problems. And the other side of it is very important is the safe blood product, particularly the TTI transfusion related infections, very, very important what the methodology that particular blood bank is using, and then also the blood product consistency from the family side, because ideally they should take transfusion from the same blood bank and the transfusion center, then you can maintain better quality. So in the infection screening also, there are they gone the old ELISA, those things, emulsions, and now the new one is NAT, very important because we've seen several issues recently coming through the paper. So it is very important that transfusion center and blood bank should follow the whatever the mandates being given across the globe. And obviously, the other thing is to prevent side effects. Saline washing was used to be a big thing, but apart from that, the filters or even the depletion, leukocyte depletion, even at the blood bank level. So these are all very, very important, because getting just blood is not enough. It's very important to have a safe blood and right transfusion. Thank you, Dr. Sirisha.
Yeah, so as you rightly said, sir, it's a required evil. So we all need to be very careful in terms of like donor screening, collection, meticulous storage, and during administration, safety measures. All these things are very important. Dr. Parinitha, can you please tell us like how do you monitor the transfusion reactions? How do you take care of transfusion reactions?
So transfusion reactions, the first thing that Dr. Ramana was, sir was saying, is prevention of the transfusion reaction is the key. So prevention is the key, because that's why the most of the methodologies used in modern blood banks, they're able to prevent most of the transfusion reactions. And with extended red cell phenotyping and proper adequate cross-matching and depleted products, we are able to prevent transfusion reactions, number one. And of course, if that is the best strategy, and what if we end up, if the child ends up having a transfusion reaction, first thing is proper monitoring in the transfusion centers for immediate reactions. That is being done, mainly the vital parameters, and for vitals like fevers and hemolysis, signs of hemolysis and all. If there's an immediate transfusion reaction, we usually advocate use of hydrocortisone, Avil, and sometimes even adrenaline. But usually that is not necessary. And routine pre-medication is not being recommended in modern transfusion strategies. So we are recommending against routine pre-medications to avoid transfusion reactions. And later transfusion reactions, when you have to warn the patients when they go home to monitor for fevers and pains and signs of hemolysis, hematuria, etc., and ask them to come back if they're experiencing any of these reactions. One of the most dreaded issue with transfusions is the development of alloantibodies. So this is the most difficult issue, and usually we diagnose it when their transfusion requirement goes up suddenly. Mainly, one, we have to rule out hypersplenism. The second thing is look for alloantibodies. Once alloantibodies develop, it is very difficult to treat this issue. We have to again re-cross match and look for extended phenotype of the child at that point, and look at what antibodies the child is having, and transfuse type specific, even minor antibodies we have to look at and transfuse accordingly with extended cross matching regimens. So, but treating it is quite difficult once it happens.
Yeah,
I hope that answers most of the thing.
Yeah. So definitely, in non-immune, you see all these febrile reactions, bacterial contamination, extremely rare but can occur. And in immune-mediated, as you mentioned, immediate hemolysis or delayed hemolysis. And in delayed hemolysis, you have to be aware of your antibody formation, and then having a extended antigen typing in the beginning itself. will definitely help in managing these children when they develop the complication. So Dr. Suman Jain, so the same child started on regular transfusions along with supportive care and then hemoglobin level being maintained. What are the other parameters you monitor in these children? I think you partly mentioned what is the comprehensive care of these children?
Right.
Precisely.
So every routinely we do all this test because serology, as you have mentioned, like the safety of the blood, we come to know, and that is every 6 months we do serology, and every 3 months we do liver function test, and plus CBP is already been done, and every year we do after 8 years of age. Endocrinal parameters like T4, T3, T4, TSH, and blood sugar. And endocrinologist, if he says ki you have to do growth monitoring, the growth hormone and all those tests, it is only on the advice of endocrinologist. And then bone growth also, bone parad DEXA scan, and then T2 star MRI once in a year, and 2D echo again once in a year. If need arises, then we can repeat T2 star MRI if it is very high every 6 months. That is what we do, the post transfusion, and serum ferritin.
Yeah, absolutely. Along with regular transfusion, we need to monitor for iron overload, and then iron overload causing various complications in end organs, as you all mentioned. So this is like just a theory part, like how iron, every transfusion increases the iron overload in the body. And we all know that we start monitoring the iron overload after 10 to 12 transfusions. Dr. Srikanth, what are the various ways of monitoring iron overload? Can you enumerate?
Yes, ma'am. So firstly, we need to know when to start monitoring for the iron overload. So once the child has completed 10 to 15 transfusions, or 1 year post the diagnosis and child is on regular transfusion, so that is when we need to be alert that we need to concentrate on checking the iron overload and other parameters. So there are different ways how we can check for it. Most common way and most which we adapt in day-to-day practice is the serum ferritin, because it's very easy to check the serum ferritin. It's just with a draw of blood sample. You can know the ferritin levels, and to an extent, they are. It's a very good marker, easily available. You can do it on almost every of your patient. But sometimes what happens, serum ferritin may not correspond to the degree of iron overload, especially if the child is being on a chronic transfusion therapy or 10 years, 7 to 8 years post transfusion. We don't know what is happening with the organ level, organ damage. Especially the ferritin, to some extent, it correlates with the liver damage, but cannot tell about the cardiac damage which is going on. So there are other parameters where we need to know, as Suman Jain ma'am has already mentioned, T2 star MRI. So this is mainly for estimating the liver iron concentration. So ideally, the gold standard method is the liver iron concentration, which tells about the deposition of the iron in the liver. So we can, best method is by biopsy, but obviously we cannot do a biopsy in every child and it's not feasible. So T2 star, by the ways of T2 star MRI, you can know the liver iron concentration, and you can also note the cardiac overload, because serum ferritin does not correlate much with the myocardial toxicity which is happening. So T2 star MRI will give a very good evidence, and it is available at many places. So we can do T2 star MRI on the patients who are being chronically transfused. And there are other various methods as well, by SQUID, so that is super quantum interference devices, use of paramagnetic radiations, but it's not available and not feasible, especially in developing countries like India. 24-hour urinary iron estimation can be done on children who are on chelators, but they are not very specific as well. So mainly it is serum ferritin and then T2 star MRI, which has to be done.
Yeah, so absolutely. Though serum ferritin comes with certain disadvantages, being like an acute phase reactant, and though you cannot directly correlate with the iron burden in the internal organs and all, though as it is easily accessible, cheap, inexpensive, and then you can adjust the dose immediately based on the result. Going by that, serum ferritin is commonly used, as you said, but at the same time, we need to monitor at least once in a year T2 star MRI after 7-8 years of age to accurately adjust the dosage of your chelators to achieve the optimal iron chelation in these children. So, Dr. Pradeep, can you enumerate various iron chelators and what is your first choice in a newly diagnosed case? So, Dr. Pradeep, I think got disconnected again. Okay. So, someone wants to go ahead and take up the question. Dr. Sandhya, are you there?
I think Dr. Pradeep is traveling. He has issues on connection. So I request
Okay, sir,
Madam
no
to
worries.
distribute it to either Suman Jain Madam or
Dr.
Srikanth.
Suman, can you tell us various
Yes.
iron chelators and what do you start in newly diagnosed case?
Yeah. In a newly diagnosed case, like we have got two oral iron chelators like Kelfer, Defriprone, and Deferricirox and Asundra or Defrizet and all. And one parenteral iron, it is injection Desferal. So we start with our children at the age when after 10 to 15 transfusion with the Kelfer, which is called Defriprone. And after starting Kelfer, we monitor like serum ferritin and all. If it is doing well, we don't change the drug. And if the serum, sometimes when the adolescent period comes, the children are very much, they are not adhere to the treatment. Adherence is the question, Then we have to start with the two oral iron chelators or sometimes the injection Desferal. So these are the three drugs which has been used for iron chelators. And we prefer oral chelators, and Deferricirox is a better drug because it will be given only once in a day. That works very well with the children with the case of adherence.
So absolutely. So when you use the drug, as you said, you want it to be easy to administer. That is once a day. It has to be effective. So that is like, among both the oral iron chelators, we all know that Deferricirox is the most effective. So going by that, that will be the first choice when you are dealing with a newly diagnosed case. And though it is FDA approval has come first before Deferiprone, but practically Deferiprone is there in the usage right from 1990s. We all know that.
Right.
So, however, the choice right now in the current for the past 1 decade is like Deferricirox. So, Dr. Sandhya, are you there? Can you tell us the side effects of iron chelators and how do you monitor the side effects of iron chelators?
So, as you rightly mentioned that in the current age, Deferricirox is the first choice of chelation for most of the patients because of ease of administration as once daily. The common side effects that we see with Deferricirox is gastritis. Most of the children have trouble tolerating, causing acute gastritis, feeling of nausea and vomiting. This can be managed by other methods like administering the drug first thing in the morning and then after half an hour to 45 minutes gap, ask them to eat something. Sometimes we do use PPIs or other medications, but they should be away from the administration of this drug. Other side effects that we see with Deferricirox are allergic reactions, which are possible in some cases, but not very common, thankfully. And rarely it may cause kidney and liver dysfunction, kidney dysfunction more. So in such children, we should regularly monitor the creatinine, renal functions at least once in 3 to 6 months, depending upon how the child is tolerating the medication. Coming to the other medication, Kelfer, that is Deferiprone. So Deferiprone also can cause some amount of gastritis. One of the major disadvantages is thrice daily administration of the drug. So adherence is an issue with this, but very major complication can be agranulocytosis, that is leukopenia with neutropenia, which causes increased risk of infection in these children, and arthropathy or arthralgias, joint pains, leg pains causing difficulty in walking. Sometimes even inflammation can happen with this drug, which leads to its discontinuation in most of the cases. Desferal, though yes, it is the go-to drug where you have a severely iron overloaded child who's not responding to either single or both oral chelators. So when a child is on Desferal, it is very important to regularly monitor the vision and the hearing of the child, at least once a year, if not more, because it is known to cause retinal toxicity and also causes sensorineural hearing loss. Other problem with desferol is it can cause allergic reaction, especially when given during in the subcutaneous route at the site of entry. Bad allergic reaction can happen, and septicemia, especially with organisms like Yersinia and Klebsiella, it can lead to bad septicemias. Desferol is also known to cause renal dysfunction. So again, here whenever a child is on multiple chelators or any specific chelators, it is very important to regularly monitor the renal function and the liver function at least once in 3 to 6 months. Ferritin, definitely to know at what rate it is falling. So if it is going below 1000, we have the liberty of reducing the dose of the drug to ensure better this thing. And also we need to do vision and hearing tests for any child who's on desferol regularly.
Yeah, so absolutely. So we have to not only the initiation, also the monitoring for the efficacy in terms of checking for the iron overload by various methods Dr. Srikanth enumerated, and then also we need to check for side effects of those medications as Dr. Sandhya mentioned. And one thing what we can do is deferoxyrox when it is causing gastritis. I have seen some of the kids in the past when we were not using FCTs, film coated tablets. They used to undergo, like, a couple of my kids, they used to undergo endoscopies repeatedly for peptic ulcers. It can be sometimes that bad also. But after introduction of FCT, it's completely like that gastric symptoms and all have subsided. So that is one major complication with that, but it can be controlled either with the PPIs or by changing to FCT preparation. And other side effects have been mentioned. One thing I want to show in this picture is bullous retinopathy, bullite retinopathy, where it can be silent complication which needs to be monitored yearly. So as Dr. Sandhya mentioned, biochemistry every year, other than that, every 6 months. Other than that, eye checkup every year to rule out the retinopathies like this, as it can be silent and it can cause visual problems in the future. So, and most of the drugs can cause, like all the three drugs can cause this, but mainly for the desferol, you have to be very careful. Dr. Suman, can you mention what is, so I think you have already spoke about the comprehensive care. I'll skip this question. You have already mentioned about the growth, endocrine function, how to monitor bone health.
Shirisha, I want to tell one thing in the side effect of deferoxyrox. We have
Please
seen
go ahead.
one child.
Yeah, please.
One child had a bilateral cataract development after deferoxyrox.
Okay.
So we have to be little. The eye checkup is very important and all that is, but it is a very much side effect, and where we can't use this drug again. It is a permanent, like you have to hold the drug. We can't use this drug in this type of cases when the cataract develops.
Yeah. Okay. Thank you for sharing that. And so monitoring for all the patients with all the parameters that has been mentioned: biochemistry, endocrine assessment, growth, bone health, vision, auditory function, all these things needs to be checked. And at the same time, we also have to monitor their bone health meticulously. So I think Ramana sir would have seen, like, most of the young thalassemia children growing into young adults in front of him, and then he knows what are the various endocrine complications one practically face, as well as how their bone health can fluctuate. Ramana sir, can you please elaborate on this for us?
Yeah, basically, when you talk about thalassemia management, is all about is the quality of life. That's very, very important. And first and foremost, it to start with a good transfusion program. That is very important. There are a lot of issues, unseen and seen issues, which need to be sorted out. And I think, the kind of a blood bank or transfusion centers, they should go through proper kind of a quality check. That is very, very important. And the second one is iron complications, as already been talked about it. Third is most important is the endocrine complications. So kind of we all know that high iron levels can impact permanently a lot of the organs. So our aim should be about how to prevent or prevent the endocrine complications or early recognition. These two are important. The first and foremost would be, as already my co-speakers spoke about it, of the how to monitor various complications. Very important is from 9 years onwards about talking about the growth, because that is the time you can recognize early and you can intervene. And the pivotal changes, once they are kind of reaching 11 years, then you have to be. And sporadic, the complications like diabetes, hypoparathyroidism, and the other one were aptly to be recognized early.
Yes, sir. So as we all think that probably hypothyroidism is the most common, but in practical world, hypogonadotropic hypogonadism is the common, and then comes your hypothyroidism and other complications like diabetes, hypoparathyroidism, and others. Bone health is very important in these children. We always have to go ahead and ensure that they take regular calcium supplements, vitamin D supplements, and we need to encourage them to get their levels related to those biochemistry like vitamin D levels and calcium levels and all. And at the same time, we also have to monitor the bone health with DEXA scan wherever there is an availability, but it is not practical in most of the centers. But at least simple things like bone alkaline phosphatase and these kind of things one can do. And other than that, we also have to encourage them to have a regular healthy lifestyle in terms of physical exercise. That will also ensure the bone health of these children. So that is how one can go ahead and ensure the good quality of life. Dr. Srikanth, this question is for you. So there's an 8-year-old boy with thalassemia major on regular transfusion and chelation therapy. His weight is suboptimal and height is also short. How will you evaluate this child? He's just 20 kg and 106 centimeters at the age of 8.5 years. How do you approach this child, Dr. Srikanth, practically?
Yes, so looking at this child, so he's been on regular transfusion and chelation therapy, and the height is definitely less than third centile. We can see 106 centimeter for an 8-year-old child is definitely short stature, and weight is also just maybe around the third to 10th centile, 20 kg. So again, here history and examination becomes important here. So for history wise, we need to ask them what are the pre-transfusion hemoglobin levels is the child maintaining. So parents may say, yes, we are every monthly we are taking transfusions sir, and chelation we are giving every day regularly. But we need to know what is the pre-transfusion HP, because that may hamper the actual growth itself. So the pre-transfusion HP is very important. And how frequently are they taking the transfusion? Is it 3 weekly, 2 weekly, or once in 6 weeks? So they say they takes 1 in 6 weeks, and they say they're taking regular transfusion. So that history is very important. And diet also becomes very important in the history wise. So many times they tell there have been a wrong notion that we need to avoid these foods, we need to avoid iron rich containing foods because child is on iron overload and all. So we need to concentrate and emphasize that it is iron absorption through the food is very less. And if they start avoiding all the iron containing foods, the nutrition per se, the vitamins and all the micronutrients which are needed are also being the child will be deprived of all that, and that also can cause a short stature and malnourishment for the child. So the history, and then chelation therapy, because we know desferoxamine can cause skeletal abnormalities. So if they are on IV or subcutaneous chelation therapy, then we need to see, because if the child is having skeletal abnormalities because of the chelation, then upfront we need to stop the chelator and switch over to other mechanism. So then on examination, look for the gross hemolytic phases. So that itself gives an indication that child is not being adequately transfused and chelation is not going per se. And then later on your investigations comes up, like you need to do a thyroid function test, because there can be hypothyroidism. And once the child is 9 years, 8-9 years, a definite Tanner staging has to be done as a routine checkup. So once in 3 months, whenever the child comes, always plot the height and weight in growth charts and look for the Tanner staging. And then based on the need, we have to even definitely check for every 6 monthly calcium, phosphorus, vitamin D levels. If not testing, at least ensure that they're taking the supplementation, calcium and vitamin D. so that at least the bony deformities because of the deficiencies would be avoided. And then later, based on the need, based on the endocrinologist opinion, we can do the tests like FSH, LH, testosterone levels, based on the case-to-base basis. MRI brain also can be done because, as ma'am has already mentioned, the most common endocrine abnormality is hypogonadotrophic hypogonadism. So doing MRI brain, you can have a small pituitary. So small pituitary gland itself can tell that the child can have all the endocrine abnormalities setting in. So this is how we would like to go about the management of the case further.
So very appropriately said, Dr. Srikanth. So there are many things before you go for endocrine testing. There are many things you need to look at, like adequate transfusion, nutrition, care, chelation, side effects of chelation, and then go to the endocrine aspects of the growth problems. So that is how we approach and do the tests, and then accordingly we take the action to correct the short stature in these children. Back to the case like Ramana sir, if the same child is having poor increment post transfusion and coming within a week or 10 days for the next transfusion with increasing jaundice and persistent severe anemia, so what will you think of? And then what are the causes, different causes, and how do you act on this case?
Usually, one thing we should look at it is whether child developing alloimmunization. That's very important. And we often, what I found is lot of the times these families with irregular transfusions and then significant organomegaly, they tend to run pre and post transfusions also low. So these are the two main things what I would look at.
Yeah. So one is we have to look at what is the pre-transfusion. Is it very low? If it is very low, then go ahead and suspect. And at the same time, your child is having increasing jaundice, plus minus cola urine. Then you have to go ahead and suspect are there any antibodies, and then act according to the situation. And at the same time, it can be autoimmunization or alloimmunization, forming autoantibodies or alloantibodies. Then you have to go ahead and act accordingly. And at the same time, we also have to look at the, as sir mentioned, hypersplenism is red cells are they breaking in the big spleen. So do we need to take care of that first before we jump onto the advanced or fancy investigations? Dr. Parinitha, can you tell us the
one more point I want to add is
yes, sir.
The one thing is malaria. Still, you have to be very careful. Now and then we come across these cases which can be easily treatable. We had quite a few kind of instances where you treat and they get better.
Very true, sir. Yeah. So because common things always you have to look at, though you have a different diagnosis here, we should never forget about the common things particular to that area. Yeah. So Dr. Parinitha, can you tell us the various treatment options when you have auto or allo antibodies? How do you take them forward in the treatment?
Very difficult question. I always get this question. I don't know why. So the first thing I would say, as I've said before also, is to prevent this situation is the ideal thing to do by, as you've already mentioned and I have alluded to before, it's one of the complications that is very, very difficult to treat. So prevention is a major thing, and mostly by extended red cell typing prior to the first transfusion and with each transfusion as well. So the first thing that we do for these kids is that we have to use extended cross-matched. First of all, identify what is the antibody. That is the first step in the whole issue. So what is this auto or allo antibody that is present in this child's blood? And use, with the help of transfusion medicine consultants, take the help and get them transfused with extended cross-matched blood against, that's what we use all the time in these kids. Now, that is one thing to maintain the requirement. And how do we actually, if that is not working out, then we have to look at the treatment options. Now, treatment options are limited. We can try various things. Like first thing we tried in a few of our patients is rituximab. And what we have noticed is it hardly ever worked in our situation. Obviously, one auto antibodies, you can try steroids, IVIG and all that, but alloimmunization is what I'm alluding to most of the time, which is more common. So rituximab is what we have tried, and sometimes steroids, IVIG, but it can work to a certain extent, but it is a very challenging situation overall.
So absolutely. So as you rightly said, for auto steroids, IVIG works more, but for allo, they can help to some extent, but mainly we also have seen the response to rituximab in these cases. And of course, as you rightly mentioned, prevention of this situation is more important by doing the extended red cell phenotype. That is main thing that we have to take care of. Dr. Parinitha, can you also mention at the same time about role of splenectomy in these children? We have not touched that aspect.
Role of splenectomy in thalassemics?
Yes. Yeah.
Yeah. So
in general.
Again, we have to prevent this situation from happening with the current transfusion regimes. So if we maintain an adequate hemoglobin level of more than 9.5, we can usually avoid hypersplenism issue. But if that is the situation and the child is, the RBC requirements are going up heavily, and if it reaches more than 250 to 300 ml per kg per year, then we have to consider splenectomy. And despite that much requirement, if the child is still not able to maintain the hemoglobin levels that we aim for, then splenectomy can be considered, and that is a time when we do the splenectomy, when we advise splenectomy.
Absolutely. So with the regular transfusion, good counseling, and good follow-up, we should be able to prevent this situation so that we can prevent the child growing into society with hemolytic phases and huge spleen and abdominal discomfort and cytopenias and all. However, if we face this kind of situation, as Dr. Parinitha said, if the transfusion is touching up to 300 ml, or even if it is touching up to, but if the compliance, once again, at that point of time, if the family is committed, one can go ahead and give regular transfusion, one can do cytoreduction with the hydroxyurea, and then you can control the spleen. Once you control the spleen, then regular transfusion program can go on. However, if you think that the child's compliance is once again going to be poor and has rare blood group with huge spleen where the transfusion requirement cannot be met adequately, so in those kind of situations, definitely one has to go ahead and do the splenectomy. And we all know that child requires 1 month pre-vaccination for capsulated organisms, and then later prophylaxis with the penicillin. So, Dr. Sandhya,
Yes.
what are the curative options for thalassemia, and what are the prerequisites for stem cell transplant, and what is the success rate of stem cell transplant?
Currently, if you're talking about curative options, the only available option right now is a hematopoietic stem cell transplant or a bone marrow transplant for thalassemia major. The prerequisites, one of the most important prerequisites for a transplant is the child's health status, that the child should be adequately transfused, well-maintained child with good iron overload management, and preferably less than 7 years of age. And the other major prerequisite for transplant is availability of a donor. So if you have a 10/10 fully matched, HLA matched donor, sibling donor or a related donor, the success rate of hematopoietic stem cell transplant in thalassemia approaches 90%. This is one of a major success story in pediatric transplants. So if we have a fully matched, HLA matched donor, the success rate is excellent. But given the current latest facilities that are available for us, even matched unrelated donor, if you have a fully matched unrelated donor, with the modern techniques of managing GVHD and immunosuppression and preparing the patient well, we can achieve very good success rates even with a matched unrelated donor, and for the matter, even a haploidentical donor where either of the parent, whoever is a better match for the child, can be a donor for the child. Definitely that will be a more complicated transplant process, but with the modern techniques available with us for management of GVHD and other infections and all, it is definitely a doable thing for treating these children. Very other prerequisite, as I said, there is something known as a Pesaro's classification for children thalassemias, which give us an indication which child will be a better candidate who will tolerate the transplant process better, and the success rate is higher. So in this, we see certain risk factors for the child. One important factor being regular transfusions, good iron management, and liver status. So hepatomegaly or presence of liver fibrosis is an adverse risk factor. Inadequate chelation is an adverse risk factor. A child who has been irregularly transfused is an adverse risk factor. So any child who has all good factors in this and is less than 7 years of age comes as class 1, who is an excellent candidate for transplant. Any child who has all 3 of these risk factors becomes a class 3 and is a poor candidate for transplant.
So absolutely. So the most important thing is, as soon as younger the guideline says, like, they don't mention like less than 1 year, but they say like as early as possible. That means like, around 1 to 2 years of age is the ideal time to transplant, but majority of the times transplant happens between 2 to 5 years in an ideal situation, but many come even after 5 years. Then we have to go ahead and look at this Pesaro classification, where you put them into high risk group and good risk group and intermediate, and then go ahead and counsel the patient accordingly. And you have to prepare them with the hypertransfusion program, hydroxyurea prior to transplant, to create the marrow space for the stem cell to go and engraft in the marrow. And at the same time, you have to give irradiated blood products to prevent the GVHD post transplant. So, and very good iron control. Good iron control will ensure the transplant success by preventing many complications post-transplant. So all these things matters before you go ahead and transplant them. Dr. Srikanth, can you tell us like what are the other modalities, like newer modalities? Is Dr. Srikanth around?
Yes, ma'am.
Yeah.
So apart from the transplant, which is curative, I mean, the other thing which is other newer medications have been come, but they are not curative options, but they can be used. So we have a FDA approval for a drug which is known as luspatercept. So though it is an expensive medication, but giving every 3 weekly for a duration of time for around 3 to 6 months can decrease the requirement of the blood products and can decrease the transfusion requirement, maintain good hemoglobin levels. So the quality of life can be improved by using of that medication. And gene therapy.
Essentially, you are converting THAL major into THAL intermedia,
THAL intermedia
into non-transfusion dependent completely.
Yes,
so that kind of change you can see with luspatercept. Other curative option. So luspatercept is not a curative option, but it will give the better quality of life, as you said. However, gene therapy is one curative option where, yeah, so it is definitely not done in so far in India, but abroad it has been tried and it has been proven to be successful in these children. However, one has to wait for the long-term results. Yeah. So, Dr. Suman, the most important aspect of the day, the question goes to you. That is like, where do we stand in terms of prevention of thalassemia in our society? And then what are the measures for the same? And what are the challenges you face when you are screening? What is your experience? Can you tell us on these aspects?
Like, I'm very happy, like, people are talking about prevention, because this is the disease which is easily preventable if the government make up their mind, making this test compulsory at least in the first trimester of pregnancy. Like in our setup, in our society, we're doing, and many siblings are found to be carriers, and uncle, auntie, and their cousin brothers and sisters are found to be. In those type of families, nearly 50 to 50% of cases are carriers in extended family screening. So the percentage is very high. But what we are doing,
Somebody has to mute. I think, please, others, if they can mute. Other than the speaker and moderator.
And another thing, like we are doing this screening in the paper has also been published in Government Maternity Hospital, Petla Bruj. Nearly 3,600 antenatal mothers we have screened with the study started in I think March 2021 and we found the antenatal mothers around 2.4 to 2.9% of them are carriers, and and 3 of the husbands found to be carriers, and we sent them for prenatal diagnosis, and luckily all the fetuses were found to be normal and they have continued the pregnancy. So this is the thing, and there is a study in Taiwan where for last 20 years the antenatal screening of mothers, and they have reduced from 15% of their hemoglobinopathies to 0.001%. So it is a very big tool, and the government has to pass a rule. Like otherwise, the gynecologists, they don't make this test mandatory. They have to make it a mandatory. Find out the government rule to be what they say. Some government rule to be passed so that it will come into a antenatal screening panel. So this is the one way to reduce, and we can easily prevent, like how many countries, everybody knows, Cyprus, Sardinia, they have controlled this disorder.
Yeah,
thank you.
As you rightly said, there are many steps at which we can control this thalassemia major. Of course, minor status is like very aggressive. The incidence is quite significant, which gives surprise to many people. In different communities, it can, in some of the, in southern part, like though it is 3% in northern India, or in the other parts of the country, it can go beyond 10 to 12%, 13% also. Go in states like Gujarat, Punjab, and also going by that, we have to be very careful in screening them at various steps, if possible, even in schools, colleges, antenatal mothers, and everybody needs screening. And we all have to take the pledge in preventing further thalassemia major incidents in our society. And I think the challenges, Dr. Pradeep is not here to make the comment on setting up the unit in district places. Suman Jain, probably you can only comment on that. Like, what are the challenges in setting up the unit in district places?
Like we have started our center, daycare center in Khammam and Kurnool. And main challenge what we are facing is the blood and the safety of blood and all, which is a very big challenge. Otherwise, the training part of the doctors we have done, the nurses we have done, but the blood part is the big challenge. I find that is the big challenge.
Very true. Availability of the blood, safety of the blood, understanding of the people in the local area, especially when you tell them about the screening. So about the girl may be minor, and then to mention that girl is a minor before marriage itself is a big challenge for in our society. So there are various practical aspects. So, Dr. Prajna, can you please tell her, what is the ideal time for antenatal testing in these children, various antenatal testing methods, and how do you counsel the family who come to you for the antenatal testing?
Yeah. So basically, counseling begins with in addition to all of what has been already discussed, the genetic basis of the disease, why the disease occurs, what is the natural cause, what are the treatment options. These are the things we begin with. The next component is the pattern of inheritance and the risk of recurrence. So beta thalassemia, we know, has an autosomal recessive pattern of inheritance, which means that in almost all cases, with a few exceptions, both parents would be heterozygous carriers. With 2 copies of the gene, each of the parents will have a mutation in 1 copy. And if the child happens to get both defective copies from both parents, then the child is going to get the disease. So there is a 1 in 4, that is 25% risk for each offspring of carrier parents to develop the disease, to inherit or have the mutations and have the disease. So, so this is if the parents are carriers, there is a 25% risk of recurrence in each offspring. Now, because many of them are now doing well with transfusions, with chelation therapy, they are, getting married, even having children. So now, and especially the thalassemia intermediates, many of them do get married and, they come for counseling for themselves. So if one individual is affected with beta thalassemia, as long as the partner is not affected or not a carrier, there would not be any significant risk for the offspring. Because even if the person is affected himself or herself, he or she would be passing on only one mutated. If the partner is not even a carrier, then the child would at the most just be a carrier and not be affected. But if the partner happens to be a carrier of an if the affected individual is there, his or her partner is a carrier, there would be a 50% chance for each offspring of such a couple to get the disease. So this is about the risk for each offspring. So this is the counseling that is given to the family. Now, how to go about doing prenatal testing. So if we need to do prenatal testing, we need to have the mutations identified, because hemoglobin HbA1c is okay for diagnosis of the proband. But when it comes to doing prenatal genetic testing, we know that HbA1c really would not be an option because the fetal HbF fraction will anyway be high in the fetus. So we cannot use HPLC as a, there are ways of doing it. Previously, people used to do when molecular tests were not available, but they're not very, HPLC based prenatal testing is not at all reliable. And reliable prenatal genetic testing based on molecular genetic testing of the fetal DNA. And for this, ideally, we should identify the mutations in the affected child, the proband, the index child beforehand. If the proband is no longer alive, in the parents, we should identify the exact mutations. And then only the fetal sample is taken. And in the fetal DNA, we look for the specific mutations which are already identified. Even when we do carrier screening in the general population, if we find that both partners, if you find one partner is a carrier, we do carrier testing for the other partner as well. If both of them are found to be carriers, HbA2 is elevated, or one is a beta thal carrier, the other one is a sickle cell carrier, let's say, or one is HbE carrier, other one is beta thal carrier. In all these scenarios, we can offer prenatal genetic testing. There again, once you've done the carrier testing, identified the carrier status, first and foremost, you do the mutation testing for the partners, identify the exact mutation, and then only we do the prenatal sampling and look for those same mutations in the fetal DNA. So for antenatal testing, there are two main methods. One is either chorionic villus sampling, which is done at 12 to 13 weeks of gestation. You can do it as early as 11 weeks also, but not earlier than that because of increased risk of limb reduction defects and so on, because of earlier CVS. And the other method of doing it would be through amniocentesis, which is generally done between 16 to 18 weeks of gestation. Between the two, CVS may be a better modality because you are able to do it earlier at 12 to 13 weeks itself, so that your reports come in by the time the lady is about 15 to 16 weeks gestation. And if there's if the fetus happens to be affected, they can go for earlier termination of the pregnancy. Of course, the risk of pregnancy loss is a little more with CVS, not so much more. Risk of pregnancy loss with CVS is about 0.5%. With amniocentesis, it's about 0.1. What are the two methods most commonly used for prenatal testing? If the family presents later or something, some occasional cases you may do chordocentesis. The cord blood may be taken, but that's usually associated with higher risk of pregnancy loss. It's also technically more difficult to do. So very few people actually do chordocentesis for this prenatal testing scenario. So you do the CVS or amniocentesis procedure, you take the sample, you rule out maternal cell contamination in that. After ruling out MCC, then in the DNA, the specific targeted mutation analysis is done for the mutations already identified in the index child or in the couple. And then you determine whether the fetus is affected or not.
Thank you very much, Dr. Prajna, for explaining all the details. So as Dr. Prajna mentioned, there are the various methods, and we should have a index child mutation in advance to have the testing of the mother who is undergoing the antenatal testing. And at the same time, like, counseling of the family for especially a thalassemia child, person when they become young adults, when they come for counseling for the marriage and family purpose, we have to be very careful. We have to make sure, if the partner is normal, then that is an ideal situation where we don't need to go for the antenatal testing. And we have scenarios like that Dr. Suman and others know, like, where some of the kids in the society, they got married when they became young adults, and their partners are completely being normal. They are having a healthy life. So that is one aspect we have to be positive in that way. So not only with adequate chelation, regular monitoring, not only you're controlling the endocrine complications, not only giving the good quality of life, and you're not only controlling the future pregnancies with the thalassemia incidence, you are also giving them future near normal life by letting them getting married and then families and all. So over
There's just
to
one more thing I would like to add, Dr. Sirisha, if I may.
Yeah, go.
Yeah. So another option which can also be discussed with couples, though many of them may not opt for it, is pre-implantation genetic testing as well. Especially if they're going to go for IVF for some, maybe this may not be the primary indication for going for IVF, but if they are going to go for IVF for other indications, like infertility or something, then you can also give them the option of pre-implantation genetic testing. The embryo itself can be tested for the mutations, and the unaffected embryo can be selected for transfer. So PGT is one more option that can be also given to some of the couples.
Yeah. So I heard like there are some ethical issues related to that. Is that true, or is it there actively in India also? PGT?
So the ethical issue arises only if you try to do HLA matching in the pre-implantation or prenatal genetic scenario. If you're just going to be looking for
and
a
you
thalassemia
don't want
mutation
the
per
child
se,
if it
that's
is not a match.
absolutely acceptable. I mean, that's like you're anyway doing prenatal genetic testing. You could as well do pre-implantation genetic testing. So if you're primarily looking for whether the embryo or the fetus is affected or not for thalassemia, there are no ethical concerns there. That is ethically very much acceptable. But there have been centers and there have been some efforts at, some people are trying to do HLA matching of the embryo and trying to select only the embryo which is HLA matched.
Absolutely.
That's considered to be not really very much, ethically acceptable as of now. Because the fetus may, the embryo of the fetus may be otherwise normal, and you're not going to be selecting that embryo, or you're going to be terminating the fetus just because it is not HLA matched, would really not be very good, ethically acceptable. Yeah.
Thank you, Dr. Prajna. Very valid point. So with this, I hand over. So the essential message at the end, the message what we want to do is like, definitely we have to concentrate on preventive aspects. With this, I hand over the session back to the organizers, Dr. Yashwanth and Dr. Vamshi.
Yeah. Thank you.
Sir, yeah. Over to you.
Have we completed the session, ma'am? And we have with us questions in the chat box. I think majority have been answered by Sandhya, ma'am.
Acha. So
there are questions in the chat box.
Technology very fast. So she answered.
Yeah. So I thank Dr. B. Vijayalakshmi from NRI Medical College, A. Vijayalakshmi, Dr. Tapan Das, who is joined from Northeast. I think Aarti Kanitkar is also from BJ Pune, and Dr. Anant is there, our teacher. There are Dr. Balram, Professor Balram also has joined in. If they have any questions, they please type in the chat box. We'll complete it off. Okay then, ma'am, Sirisha ma'am, if we don't have any questions,
yeah, sir.
If any
I'm
one
just
of
looking at, what Dr. Sandhya and Dr. Parinitha answered questions in the chat box. So most of the questions have been answered.
If all the panelists want to convey the final message, I would like them to convey, and we'll close it off. Dr. Suman Jain, Dr. Parinitha, thank you, Prajna ma'am, and for all the panelists taking out some time. So you want to share one of final message Please share and we'll move off.
So already
I
it
would
is
like
written
to-
there, let's aim for thalassemia free world or thalassemia free Telangana. So that is the aim of today's and awareness.
Yeah, ma'am. Thank you. Prajna ma'am and Parinitha ma'am.
Yeah, so I agree with Dr. Suman Jain. I think the most important message would be universal screening for beta thalassemia. All couples, preferably in the preconception period or at least in the first trimester. And this should happen as a government policy. Each and every center should implement this. Then it will really be able to bring down the burden of beta thalassemia in our population, because 3 to 4% of Indians on an average are supposed to be beta thalassemia carriers. Of course, this percentage would vary with different populations, but on an average, it's 3 to 4%. So it's so high. So it's very, very important to have universal screening for each and every couple, irrespective of the family history.
Ma'am, Suman Jain ma'am, what was the antenatal screening being done at Petlaburzu? Was it only based on the CBC or?
No. We do all the antenatal mothers in first trimester. The first criteria was it should be less than 18 weeks. Because if we found to be partners also found to be a carrier, then we have to go for prenatal diagnosis. So we need time for doing mutations in the partners and then send it to next genetic department for prenatal diagnosis.
So there is a question from Dr. Tapandas. Why does the government pursue starting HPLC for all the adolescents?
The thing is that what we found in adolescence, it is a very good idea to do the screening. It is not only screening, the counseling part also should be there. You know, the people in Gujarat, this was the problem they have done in Saurashtra, like all the maximum around some millions of school children got screened, but there was no counseling. They don't know why their blood has been tested and all, you know. And if they are found to be carriers, they have not been counseled. So counseling component should be there with the with the screening.
Ma'am, does Nizams have a counseling one apart from whatever tests you do in Nizams Institute of Medical Sciences?
Yeah, we routinely do genetic counseling for each and every one of the patients who comes to us. And all the tests that we do, pre-test, post-test, everything, we do detailed counseling for them. Prenatal, prenatal testing, and then after the reports come, at every stage, basically, we do detailed counseling. So that is anyway done routinely in our department. But just coming back to that question about adolescent carrier screening, that's actually a very ideal scenario. But we have to remember that in India, there are a lot of social stigmas attached. So if, of course, a good counseling and good awareness would actually remove many of these stigmas, but sadly, you know, this doesn't yet work out in India very well. So especially if a girl is found to be a carrier, there might be some stigma involved there. There might be some, you know, she gets labeled as a carrier. Subsequently, there might be some difficulties in her getting married and all that. So that's something we need to keep in mind. The social issues involved here, social issues, aspects involved here. Otherwise, adolescent carrier testing would be a very ideal thing to do.
Thank you, ma'am. And Dr. Srikanth has sent a message: prevention, prevention, and ultimately prevention. Thank you all the speakers for having spared your valuable time. I thank all for giving us a crystal clear message to participants. Thank you, ma'am.
Thank you. Thank you giving the
Thank you
opportunity.
all. And good night.
Thank you, sir, for the
Thank you all. Thank you so much.
I should thank Sirisha madam who took day to do it after coming out from Bangalore on 2 days workshop also.
No problem, sir. Our pleasure.
Thank you, ma'am. Thank you so much.
Thank you all. Good night. Good night all.
Good night. Good night all.
Thank you. Good night.